Hello, my dear friends. I'm Dr. Kevin. First, I would like to thank Dr. Jim to invited me to join this great online conference. Because today I may have another important meeting, so I decided to pre-record my talk. My talk is ultrasound image and guided injection for the hip joint. Compared with other joint, hip joint is deeply located. Therefore, there are several structures that you may not easily access using the linear transducer. So in patients with hip joint pain, the procedure that we commonly use is the hip joint injection. But it's a very important thing is if you want to proceed the hip joint injection, you need to know the correct axis of the hip joint. The hip joint is not at the sagittal plane. Actually, is at the sagittal oblique plane. Therefore, if you want to perform the injection, you have to pivot the cranial end of a transducer toward the umbilicus. And then you can see several anatomic structures. For example, the source major tendon and the iliofemoral ligament, and of course, our target is the anterior joint recess. So you can find that there is a hyperechoid triangular structure extending from the acetabulum. The structure is labral. So if we want to proceed the injection, we have to prevent not hitting the neurovascular structure. So at this region, we have to be careful not to injure the femoral nerve. And another structure is the artery. The artery is the lateral circumflex femoral artery. As you can see, it's a branch of the deep artery of sign, and the artery would circle anterior to the iliopsoas tendon. So the arteries is usually on the root for introducing the needle to the anterior hip joint recess. So this is the Power Doppler image of the anterior hip joint. As you can see, there is artery ventral to the anterior hip recess. The artery is the lateral circumflex femoral artery. So if you want to do the injection, you have to check where the artery is located, and then you insert your needle from caudal to the cranial direction, and then you can let your needle dot the junction between the femoral head and the femoral neck. The reason why we choose this area is first, we don't want to hit the labrum. Otherwise, the patient may feel lots of pain. And then we also have to avoid not hitting the cartilage. So the best position for us to insert our needle would be the junction between the head and the neck. So let's watch the video. As you can see in this patient, there is some effusion inside the anterior hip recess, and then you can find the surface of the femoral head is not smooth, so the patient had hip joint osteoarthritis. So once your needle enter the anterior hip joint recess, you can start to push the injector to let the injector distribute into the anterior femoral recess, anterior hip recess. And when patients complain of anterior lateral hip pain, there is a structure that we have to take into account. So we know rectus femoris tendon has two heads, at least two heads. One is the direct head inserting on the anterior inferior iliac spine, and the other is the indirect head inserting on the acetabulum. So in patients with complaint of anterior lateral hip pain, the culprit could be the indirect head of the rectus femoris, and the sprain of the indirect head of rectus femoris is usually overlooked during our daily practice. So how could we use ultrasound to identify the pathology of the indirect head of the rectus femoris? So here you can find at the upper left subgraph, this is the long axis of the rectus, the indirect head of rectus femoris. And then the one below comes from the contralateral side. So as you can see at the painful side, the tendon is very swollen, and then there is also, you can find some perifocal edema. And then compare, this is the normal side. The indirect head of the rectus femoris actually is quite thin. So you can also use the short axis view to check the tendon. And in the short axis view, the perifocal edema seemed quite obvious. So if you want to do the injection, you can pivot your transducer. You can place your transducer in the coronal plane, and then insert your needle from caudal to cranium, and then your target would be the indirect head of the rectus femoris. So once your needle reaches the correct place, you can distribute the injector between the gluteus minimus muscle and the tendon. So in patients with anterior hip pain, besides hip osteoarthritis and the problem of the rectus femoris, the problem of Iliopsoas bursa has to be taken into consideration. So here you can find underneath the iliopsoas muscle, there is area of hyperechogenicity. So we can find this hyperechogenicity in the long axis and in the short axis view. So what is the pathology? The pathology is the Iliopsoas bursa calcification. So if you encounter a case like this, you can consider to use ultrasound-guided babortage to remove the calcific deposit to relieve the symptom. And after you remove the deposit, you can consider to inject some steroids. So this is another case complaint of hip pain, and then you can find underneath the iliacus muscle, there is an area of fluid accumulation. Here, actually, in normal participant, it should be the area where the labrum is located. But now you can find that the labrum has been separated by the collection of the fluid. So this is the paralabrum cyst. So you can use ultrasound-guided aspiration to remove the fluid to relieve the symptom. So in patients with anterior hip joint pain, sometimes we can find lateral effusion accumulated underneath the iliopsoas muscle. So this is the distension of the iliopsoas bursa. So we usually treat this kind of patients with aspiration followed by steroid injection. But in this case, unfortunately, after 2 times of steroid injection, the patients did not have a significantly improvement. So you have to consider what is the cause of the effusion inside the bursa. So the reason why the patient had such a great amount of effusion is because the patient had a vascular necrosis of the hip. So in many cases, the iliopsoas bursa has a connection with the hip joint. So if you find the patient has lots of effusion inside the iliopsoas bursa, you have to consider the possibility of the hip joint arthropathy, for example, the vascular necrosis of the femoral head. And in patients with anterior hip joint pain, another possibility is the trauma of a muscle, for example, adductor muscle tear. But in patients who are very young, you have to consider the problem comes from the apophysitis. So here we can find the young kids had pain over the anterior medial hip. And then we can find medial to the lesser trochanter, there is a hyperechoic bony plaque. This area is the insertion of the iliopsoas tendon. So it's likely the patient has the apophysitis or avulsion or fracture of the iliopsoas bursa. So we can compare with the contralateral side. At the contralateral side, you do not see the hyperechoic plate. So you can also pivot your transducer to the long axis to visualize the attachment of the iliopsoas tendon. So we can use the dynamic view to track the lesion. So you can track the femoral joint from cranial to caudal, and then at the level of the lesser trochanter, you can find that there is a bony plaque over here. And then you can pivot your transducer 90 degrees, and then you can see the hypoechoic plaque is located at the attachment of the iliopsoas tendon. And in patients with a snapping hip, there are 2 types. One is the internal snapping hip, the other is external snapping hip. Internal snapping hip means the snapping originated from the anterior hip joint. Okay, sorry. So here we let's look at the video to see how the snapping happened. So this is the abbreviation for the terminology I use in the picture. As you can see, this is iliacus, lateral medial, and this is the tendon. So then we ask the patient to flex and extend the hip. So you can see a splash emerging from the video. So this is the moment when snapping happened. So you can also use the long axis to reprovoke the snapping. So how did I treat this patient? Because I find that the reason why the patient had snap is because the tension between the iliacus and the psoas muscle was increased. Therefore, I decided to hydrodilate this area. So now you can see my needle is stuck between the medial iliacus and the psoas tendon. And then after injection of 10 milliliter of injectate, we recheck whether there is an improvement of the snapping. As you can see, the gliding between the psoas tendon and the iliacus become smoother. So it means the treatment is successful. So in patients with lateral hip pain, there are several structures that we have to consider. For example, for the tendinous structure, we have to consider the gluteus minimus and the gluteus medius. And there are three bursas besides the tendon of the lateral hip. For example, the subgluteus minimus bursa is located underneath the gluteus minimus, and the subgluteus medius bursa is underneath the gluteus medius tendon, and the greater trochanterior bursa is actually located underneath the iliotibial trait, and the iliotibial trait is the combination of the tensor fascia lata and the gluteus maximus. So this case has had a lateral external snapping. So external snapping indicates the snapping happens at the trochanteric region. So you can compare the normal size with the painful side. As you can see at the painful side, the tendon is quite swollen. So here, let's use the video to demonstrate how the snapping happened. So we ask a patient to flex and extend the hip. So we can find an abrupt movement between the gluteus maximus muscle and the underneath gluteus medius tendon. So for this case, if you want to relieve the problem, you can insert your needle between the gluteus medius and the iliotibial band of gluteus maximus muscle to dilate this region. And then remember, the reason why the patient has symptoms is because of a swollen gluteus medius tendon. So you have to treat the tendon as well. So now you can find that my needle is going to the gluteus medius tendon, and then I use pampering technique to distribute the detritus inside the tendon. So let's see what happens after injection. As you can see, after injection, you can find the echogenicity of the tendon improve and the thickness also decrease. And of course, the snapping symptom decrease as well. So this is a case came from a young girl, and she's a model, and she like jogging. As you can see at the problematic side, the thickness of the iliotibial trait is as twice thick as the normal side. So if you move your transducer more anteriorly, you also find nodular thickening of the iliotibial trait. So you can use the dynamic image to reprovoke what happens when the patient feels snapping. So for this case, because the reason why the patient has snapping is because thickened tensor fascia lata. So I performed tensor fascia lata tenotomy, and then after the injection, 2 or 3 times of injection, the symptom improve. So remember at the anterior lateral hip, the anterior superior iliac spine is the attachment for the tensor fascia lata and also for the sartorius. So in this case, we find there is a huge calcification at the attachment of the anterior superior iliac spine. So we suspect the patient had injury of tensor fascia lata before, and then there is calcification, and then calcification develop inside the muscle. So here we can find there is a huge calcification over here. It could be the deposit after avulsion injury, or another possibility is the myositis of cervical. So another case complaint of lateral hip pain. Actually, in patients with pain over the greater trochanteric region, the most possible lesion would be the problem of the gluteus medius tendon. So here we can find the calcification at the attachment of the gluteus medius. So the patient has a gluteus medius avulsion injury, and then you can find some appearance of enthesitis. So a less common but possible diagnosis of the anterior lateral hip pain will be the problem of the gluteus minimus tendon. So as you can see, the gluteus minimus is located underneath the gluteus medius, and the attachment is at the anterior, under the anterior facet of the greater trochanter. So here in normal participants, you can find the tendon is quite thin. But in patients with anterior lateral hip pain, you can find that the thickness of the gluteus minimus is increased compared with the normal side. So in patients with greater trochanteric bursitis, we may proceed the injection. And the target would be the iliotibial tract and the gluteus medius tendon. So once your needle enter the correct space, you can push the injectate to dilate this plane. So now let's go to the posterior hip pain. So in patients with posterior hip pain, we usually think they have a piriformis problem. But if you use ultrasound to visualize the piriformis, sometimes you can find that there is a hypoechoic region located between the gluteus maximus and the piriformis tendon. So this is not a fusion, because if you use dynamic image, you ask a patient to external and internally rotate the hip, you can find this hypoechoic region it's not compressible, and it would move with the piriformis. So this is the fat pack instead of effusion. So this is the cadaveric picture. As you can see, the fat marked by the dashed area is located underneath the gluteus maximus. So in patients with piriformis syndrome, we can use the comparative image to compare the piriformis at the bilateral site. And the most vulnerable area to have a piriformis syndrome is actually the area on top of the ischem, because the ischem is the hard surface. So if the patient has repeated compression of this region, the area on top of the ischem would be vulnerable to the compression and the cause pathology. So here, if we can perform the ultrasound-guided piriformis injection, you can inject from medial to lateral, lateral to medial. But be careful, you have to turn on the Doppler first to make sure where the inferior gluteal artery is. So this is a case with piriformis syndrome 3 months ago, and he visited my clinic, and we performed the piriformis injection. But 3 months later, he came back to my clinic. He said the buttocks pain actually did not improve a lot. So I use ultrasound, and besides buttocks pain, she also had a pain radiating to the perineum. So on that ultrasound image, we can find that there is a hypoechoic mass underneath the piriformis. And then the mass is actually very close to the pudendal nerve. You can see this is the ischial spine, so the pudendal nerve is interposed between two ligaments. So what is the mass? Actually, this is not a mass. This is the uterus. As you can see, the patient had a deviated uterus, and unfortunately, the deviated uterus compress the pudendal nerve and cause symptom. So I'm happy this article is I collaborate with Professor Carlo Martinoni and Professor Lavente to accomplish this interesting article. So let's study if in a patient with posterior hip pain, you have to consider the problem of the ischial tuberosity and cystitis. So in the painful side, you can find that there is a hypoechoic plaque on top of the ischial tuberosity. So you can visualize the lesion in the short axis view. Of course, you can pivot your transducer in long axis view to identify the lesion. So in this case, we can perform the ultrasound-guided injection. We can puncture this specific region, and then push some injectile to surround the thickened tendon. So in patients with posterior hip pain, we may consider the patient may have some sciatic problem or some muscle injury. But in this case, the clinical diagnosis is the adductor muscle strain. But when we use ultrasound to scan this region, we can find underneath the semi-tendon. No semi-tendinous muscle is an area of multiple tubular structure. So if you turn on Doppler, you can find the increased vascularity in this region. So this is not the muscle strain, it's actually hemangioma. So you have to be careful. Not all the patients with medial hip pain have the sprain or the trauma of the adductor muscles. So thank you very much. If you like MSK ultrasound, you are welcome to join. If you like MSK ultrasound, you are welcome to join MSK Ultrasound Club on Facebook. And also, if you are interested in my talk and want to learn how to inject the hip by yourself, you can refer to our article published in 2018 in AJPMR. And then lastly, many years in Taiwan, we have ultrasound workshop, one in April, the other in November. So if you, after the pandemic, if you want to learn MSK ultrasound, Taiwan could be your good choice. Thank you very much.